Good afternoon, everybody. We are about to start our second webinar. My name is Eva Watt. I'm the Training and Capacity Lead for NL Support. This webinar is part of a free training program in patient-oriented research. Our goal is to give you an understanding about patient-oriented research and the different aspects of it. One of the aspects is realizing real-world outcomes for patients. And today we're going to talk about how to translate research findings into practice. Our guest speaker of today is Amanda Hall, who is Knowledge Translation Lead for NL Support and a researcher at Oxford University Amman. And since some of you are using Blackboard Collaborate for the first time, I would like to introduce you to the different features. As you can see on your screen, you have a chat box on the left where you can put in questions, and we will answer those questions at the end of the webinar. If you have any technical questions, please call our technical support desk. And we will also using the voting feature in this webinar. So we will ask you to answer a question during the webinar, and you can do this by using the voting tool. So you can answer with, for example, yes or no. So let's practice that. Please let me know if you can hear me, and please answer or vote with yes or no. It looks like you can all hear me. We have 70 people saying they can hear us well. We are with about 40 in the room with all kinds of different backgrounds. So I assume that everybody can hear us. If you have any problems, please call the technical support desk. And I would like to inform you that this session is being recorded, and the presentation will all become available on our website after the session. Okay, I guess we are about to start. And I would like to introduce Amanda Hall for this webinar session.
Thanks, Eva. This is my first webinar, so bear with if I'm not using all the buttons correctly in the first bit. So as Eva said, we're going to be talking about making the change, or how we implement evidence into practice. And I think that I'm not sure exactly what everyone's background is in knowledge translation and this type of research. So our main objectives will be to review knowledge translation approaches and frameworks, to get an understanding of how implementation interventions fit into that framework, and to gain an understanding of how we may be able to develop implementation interventions, and also introduce you to some common strategies that you may have heard already, and to go through a worked example of some of the research I've been involved with in developing these types of interventions. Now, before we start, Eva mentioned that this is part of a patient-oriented research strategy. So while today's topic isn't focusing on how we engage patients per se, it would be great if we could keep in the back of our minds how we would be able to involve patients in this type of research as we go through. And I might have put little reminders in various slides just so that you can think about that as we're moving through the process. And we'll revisit that at the end of the webinar. So, all right, sorry, there is a learning objective. Apologies. Okay, next slide. So I'd like to start just by looking at how we actually produce evidence anyways. So this is a framework from the Medical Research Council in the UK, and it looks at how we develop and evaluate complex interventions in healthcare settings. So as you can see, there's various phases here on the bottom. And as researchers, we're probably really good up until phase 3. So where we have definitive randomized trials looking at how particular interventions may be effective in that patient population. And then we're not so good when we get to phase 4, which is looking at how those interventions actually roll out in the real world setting. So that's a big problem for us, and the reason is because we end up with a big gap in our understanding of research in healthcare settings. So this is just a review, and it looked at what are the time lags between getting our research from paper to practice. And they just estimated, it looks like about 17 years. You'll probably hear that number a lot in various research programs and how we need to be improving and reducing this particular time gap. The issue for us is that during this time where we're not using the latest evidence, we're probably engaging in what we call low-value care, or things that are maybe not the most evidence-based and are not producing the best effects and benefits for our patients. So what we'd like to do is reduce that time gap. And to do that, the process of knowledge translation has been around now for a little while, and its mandate is to try and reduce the gap between research and practice. Probably repeating myself. So where research can overlap with policy and practice is what we call knowledge translation, and where we can actually affect a change. I'm not sure what your familiarity is with different approaches, but the two basic approaches for knowledge translation would be called brokering, so knowledge brokering, and knowledge synthesis. And these are, you may not have heard these particular terms, but you're probably familiar with the types of activities in each of these approaches. So I'll just review those briefly. So brokering is really talking. It's really engaging with the people who are going to be using the research. So for researchers, they want to be engaging with policy, with patients, with clinicians, and with the public. And it's up to us to really consider who needs to be involved in that discussion and dialogue. But essentially, we should be involving everybody. Everybody we can that will be affected by the research and the evidence that we're producing. Okay, you just speak louder. So, the other types of knowledge translation activities are called synthesis, and we have multiple types of synthesis. We have formal types of knowledge synthesis that would result in meta-analyses or systematic reviews where we're compiling the evidence and providing sort of a more summary document of what we think should be happening from what we know in the research world. Or you can get things like policy briefs, so where the evidence is summarized before a policy, from a policy perspective. That might be things like business cases and how we want to see change actually happening in the clinical practice guidelines, things like that. On the informal level, what we're trying to do when we translate evidence is to put it into a much more audience-specific format. So we want to look at press releases to get the information out to the public. We want to look at different types of commercials or videos or podcasts. And I just have some examples down below of different podcasts that are available on research group websites. So the research group that's looked at here is the George Institute, and it's one that I work with currently. So for every research project that they're putting out, they kind of focus more on policy briefs, press releases, and these podcasts to really try and identify the key issues from their research and make them accessible to different patients and clinicians and research groups as well. So I think as part of MUN, we're also starting that process, and we have podcasts available as well on our website. So that's very exciting. So a framework that is commonly used for knowledge translation is the Knowledge to Action Cycle, and it's promoted by CIHR, or the Canadian Institutes for Health Research. You'll find it on their website. In the middle circle here, where knowledge creation is stated, there are different types of activities that we were just discussing. So how we produce the knowledge and how we synthesize it for different groups. Down below, you can see that it kind of starts here where we want to identify a problem and then look at the knowledge that we have and adapt it for a local context. So if we go over to the left of the circle, and then we want to assess barriers to using the knowledge and select and implement interventions to help change practice. So we're going to be talking about the left hand of the circle, where we're going to be looking at how we develop implementation interventions. So I'm going to move forward. So on this slide, I've actually borrowed this slide from another presentation we heard recently, but I thought it was quite funny. So what are we talking about when we're talking about implementation science or research? So some people say it's a fancy term for change management, and I would agree that what we are trying to do is to change behavior, but we're looking at trying to do that in this particular presentation in the healthcare setting. And if you want a more scientific definition, then you can look at Peter's paper in the BMJ. He's also produced a document with the World Health Organization, so I've put those references at the end of this presentation. But we're looking at questions that might concern any area of implementation. So if we want to carry a particular intention into effect, so that could be policies, individual practices, or clinical practice guidelines, and that's collectively called an intervention. So I'm going to focus on tailoring interventions because that is what is recommended as best practice to improve the likelihood of success. So when we say tailoring an intervention, we mean any intervention that is planned after you've done some sort of investigation or exploration into the factors that might explain two things. One, what the current professional practice is, so what's currently happening, so why is that happening, and then the reasons for why we may resist or adopt a new practice, so why we may want to follow a new guideline or why we won't. So the model for developing a tailored intervention that hopes to change behavior has been developed by this group, these two authors, Grawl and Singh. It's a bit old. It's been around for a while, but the basic steps are very similar to many models that you'll see out there. The whole idea is that you want to, in step one, develop your proposal for change. So you want to define what you're doing. You want to analyze then what is currently happening in the healthcare setting you're interested in, and from that information you need to identify the determinants of change, or how you think change can occur. In step three, the only point in here is to actually select strategies that might target those barriers and facilitators you've identified in step two. So this is sort of the meat of it, step 2 and 3. Identify the issues, target the issues. And step 4 is to develop and do some feasibility testing of the strategies you're going to put into place to make sure they're actually going to work like you thought they would. In most cases they don't, so you will need probably to do some refining, and then you can evaluate more formally. And that's part of the knowledge to action cycle as well. We won't be talking about the evaluation today, but that will hopefully be in a subsequent webinar. So what we're going to focus on today is really how we do steps 1, 2, 3, and 4. So how are we doing these? What methodologies can we use? And as we go through, it will be really good to consider how we can include a patient perspective in each of these steps. So step 1, this is an extremely important step. If you haven't done this, it might make it very hard for you to move to step 2 or 3 or have any type of intervention that's going to work. The whole point here is to come up with the problem and make it as accurate and concrete as possible. So you take a look at your current practice. So this happens during quality improvement initiatives all the time in the hospital or in healthcare settings. And you can do that with, these are the 2 main methods. So with chart audits, or called clinical audits in some cases, and or using survey techniques. So you want to see what's happening. And then you want to compare that to some form of best practice, whether that be a guideline or a health policy. And in some cases, neither of those exist, so you might be looking at a systematic review of what's known about a particular area. So in the result, so what you find when you compare them, if there is a difference, that defines the proposal for change. And you need to be very clear about who needs to do what differently, because if not, it's quite hard to develop an intervention and to understand the barriers. So if you're not sure who you're targeting, it's going to be quite difficult to begin your intervention. So some examples might be, when you look at current practice, you might find that certain outcome measures are not routinely used to assess patient change. So I'm not sure if patients are getting better or getting worse. And if the guidelines are suggesting to use a particular set of outcomes, that's a gap in practice. So we really want to improve that so that moving forward we can ensure that we are meeting patients' needs and we're improving their health from whatever we're doing in practice. Another example is if you're having a low-value treatment, so one that we defined before, a treatment that no longer has evidence to really support its use. If that's currently routinely being used in practice, and they often are, like just over time, when we get more evidence and we know that things are maybe not as useful as we thought they could be, we need to replace them with more evidence-based treatments. That's quite a difficult one sometimes to gauge what's currently happening in practice, but if you can, and you can compare it to best practice, and we know that there's a gap, then we can also affect a change there. Another example, which is quite a popular one here these days, particularly with Choosing Wisely campaigns, is to look at if there are certain tests that are being routinely ordered, but they actually don't have a lot of useful information. So they're not providing anything that will benefit the patient and or benefit a diagnosis from the clinician's perspective. So if best practice saying that has no information, we have identified a gap, and hopefully we can address that and remove that from practice going forward. So this is just an example. It's taken from a recent study on improving osteoarthritis care on a proposal for change. So this is from a published paper in Implementation Science. What you're trying to do is really identify the situation that you want to see happening here. So they've identified that they want a patient or a person who's 45 years or over and they present with a joint problem. They want to have a consultation, and they want the GP to offer them a guidebook and refer them to an OA clinic. And once they get to the OA clinic, they want to see up to 4 appointments with a nurse to support the self-management of OA, including exercise, weight loss, and pain control. So by setting your proposal up for this, you know what you're trying to evaluate later. So if you can measure that you've exacted change here, then you can show that your intervention was working. So it's good to set this up right in the beginning. Once you have set up your proposal for change, it's important not to just go headstrong into practice with that. You do need to review what you've thought as a sort of a group of researchers and with your stakeholder group. So you want your clinicians involved in reviewing that, you want your end users involved, whether that be policy as well as public, and you want to get the patient's perspective here as well. So you may decide then with that particular group how you want to present that message. So you could use various different knowledge synthesis options. So you may produce an evidence brief, or you might produce sort of a summary document that would help bring this information, new information, to your audience. So step 2, step 1 I might add is something that is probably ongoing in many cases if there's good data. So if you have good data available, you can continually do step 1, and that makes it quite easy. If you don't have good data, it makes it quite hard. So I think we're moving into a situation where we will be able to access data more routinely to manage these types of queries. Once you have that, though, step 1, your proposal for change, you can move to how you're going to analyze current practice and determine the determinants for change. So you want to know why people are behaving as observed, and you want to know what the barriers and facilitators are to using any new intervention, the new policy, or the new guideline. So you do this with the following methods in the lower box. So first of all, you may want to look at the existing literature if it's a really popular topic, like we're not using antibiotics or hand washing, those types of things. There's lots of information out there on why people are doing the observed behavior and why they're not using new practices or guidelines. So you may first look to see what's already happening. You would definitely want to be brainstorming with your stakeholder group to engage in the initial whys. And then you may choose to use focus groups or interviews to kind of explore those issues further. And you may also choose to use a survey method to get a wider perspective of what the priority barriers might be. Once you have all that information, you need to synthesize the findings. So I guess it's recommended at this point that you would use some sort of framework to help you synthesize the information you've gathered, because you've probably gathered lots of information, and the way to try and target barriers would be to have some sort of theoretical background or underpinning, if possible. So that's quite a complicated task. So over the last, I think it's about 8 years, they've been developing a more pragmatic approach to try and use theory in practice a bit more routinely and make it a bit easier for researchers and clinicians. So they developed something called a theoretical domains framework. There's actually quite a few of these out there, and this is not the only one you have to use, but this is one that's being more commonly used and has research to support the domains that they've chosen actually map onto barriers in healthcare. So the different domains that you can choose from where barriers might and facilitators might exist are around knowledge, skills, beliefs about capabilities, social influences, environmental contexts, and things like that. So there's 14 over here on the right-hand side, as you can see. And it was developed to try and make behavior change theory more accessible and usable when designing interventions. So we'll talk a bit about an example of using the theoretical domains framework here. So from your, I guess, all your data gathering, you might have identified particular barriers. And here is an example of 2 barriers that are common. So for example, clinicians may be working in isolation, and so there's no network to support the use of a new skill. So that would get mapped onto the particular domain called social influences. So if there was a more social network to support the use of new skills, then we might see that that skill would be, or that the intervention or implementation of the new strategy would be successful. So now we've gotten to a point, I'm looking at Ava, where we're going to use a bit of a question answer period. So we have another barrier here where clinicians lack self-confidence in their ability to successfully implement the strategies with clients. So let's imagine there's an intervention, there's multiple new strategies that someone has to use with their clients. Let's say their self-management strategies, they need to promote them with their clients. And one barrier was that clinicians didn't feel confident enough to be able to do that with their clients. So I guess what I would be, it might look daunting to try and map these barriers to particular domains. So I just thought I would give you an example and a chance to try to see where you might map that onto the TDF here. So here's the question. I've narrowed it down to 4 different options, and you can choose A, B, C, or D. Did I get that right, Ava?
Use the voting poll.
Yes, you need to use the voting poll. All right, so I'll give you a minute to think about that and see where you might put your answer. It's not a trick question either. So. That's good. All right, we're going to move to the next slide where we can publish the results. And I just press, oh, you did it. Wonderful. Okay, A, B, C, and D. Excellent. Okay, cool. Let's see what the answer is. It was B, beliefs about capability. So, excellent. There is some discussion, but usually what you do is you have 1 or 2 people try and rate this. If it's if you're in research and you want to do it as accurately as possible, you generally have someone with a psychology background or a qualitative skills background to help be one of the 2 people looking at the mapping to make sure you agree where you think it sits best. But that's not the only people who should be involved in that process, because you just might get it. You might have gotten the barrier wrong, for example. You might have analyzed the barrier and maybe it's not that at all. So it's really good to look at, once you've kind of established where you think the barriers are, and where you've mapped them to, so you know where you're going to start addressing it, if that's actually correct. So you want to review that with your key stakeholders again. So you want to get you want to get their input on your opinions and synthesis of information, and also what they think in general. And then you also, at this point, you also might want to consider how you could disseminate those findings. So you may want to hold a clinical practice meeting and get clinicians' opinion on these findings as well. And you also may present at different conferences where the audience that you're interested would be. So step 3, once you've identified a particular barrier, you'd want to, if you map to the TDF or to any other framework, the idea is that you select a strategy that you think is most appropriate to target that particular barrier. If it was beliefs about capabilities, generally you can look at the evidence and theory, and there's I'm going to call it a workbook for a better reason, for lack of a better word. It's called a behavior change technique taxonomy. I'm not going to go into detail because it's a whole other webinar to talk about that, but they've tried to map all the different types of behavior change techniques that are out there to the particular 14 domains. So if you are looking at how I might be able to support someone's beliefs about their capabilities, you can go to that document as a resource to look at what types of strategies have been shown to be helpful in that area. So when you're looking at selecting strategies, you can look at the theory and the evidence, and you can also look at expert opinion and stakeholder opinion. So there are multiple sources you can get your information from. We would recommend a combination of all those methods and getting the opinions from each of those sources. If I was to make a recommendation about what I would choose first, I always generally ask the stakeholders or the people involved first about how do you see this changing, or what do you want to do about this barrier? How do you want to move forward? What do you think would work best? Getting the person who their behavior you're trying to change, their opinion first, is really going to help you understand a bit about what their needs are. So triangulating the information from theory, evidence, expert, and stakeholder opinion is the approach that we want to use, if possible. This is an example. It looks a bit complex and complicated, but essentially if we were looking at beliefs about capabilities, that's down the bottom. If you're looking at a behavior change technique, that's a BCT, and I should have elaborated that acronym there. But a behavior change technique from that workbook or resource would be monitoring and feedback. So you might monitor someone and provide them feedback on how they're doing, and that should improve their confidence that they're able to do it well. Expert opinion might call that audit and feedback, and there is evidence to support the use of this particular strategy to target that barrier. If you're looking at stakeholder opinion or clinicians, they often suggest practice sessions would help them feel more confident that they're doing it right. And that's similar to what you would expect if you were in an education-based setting. So if you're trying to use a new strategy, you want to try it out and have some practice, have someone tell you where you can improve at that point. And the evidence might also suggest using a graded activity approach, so where you teach people small bits at a time and get them comfortable with little pieces and then move them and progress them to the full activity. So those are just options. You need to review these to understand what people the end user is going to like, what they think is going to be feasible. So you may want to provide audit and feedback. You may want to have someone come in and teach people to do it, but if you don't have a resource to do that, you may need to look elsewhere for other options. It's also great if there's any evidence to support it working in a similar context to what you're looking at. And that's pretty hard to find in terms of implementation research, because the context, they vary so much across different healthcare settings. And oftentimes the implementation interventions aren't defined very well in the literature, so it becomes quite a complex task to understand if a particular strategy may work for your setting just from the literature alone. So as with everything, I keep putting up this piece, because at every stage you should really be engaging with your stakeholders. You don't want to run ahead and move forward with a plan without discussing that with them first, because it will often fail. So you want to then create a deliberate dialogue about the choice of the strategy, any foreseeable problems with implementation, and options for delivering each strategy. And that will prepare you for the next step, which is step 4. And this is the fun bit. I call it the fun bit, but it's actually quite a challenging bit. So we might have suggested that now we're going to do audit and feedback, or provide practice sessions to help the clinician learn new strategies. But now it's figuring out how you're actually going to put that into practice. And that's a much longer and sometimes trickier task. This is again an example. It's a written example, which isn't very exciting, but if we look at the bottom box again, just looking at beliefs about capability, so we may have chosen self-monitoring and feedback as the actual technique we're going to do. So we're going to have the clinicians monitor themselves, and then we're going to provide feedback to them on how they're doing. The mode would be called audit and feedback with a focused coaching perspective. So you're going to have someone actually help coach them through the process. So this is actually taken from a project that we did in Ireland on helping physiotherapists learn different communication strategies about how to promote self-management for patients with back pain and arthritis. So they did different recordings using the Connect strategies after each session, and they were provided written and verbal feedback on how they could improve those their strategies for the next time. So that's just one particular example of some implementation strategy. So audit and feedback is a really popular one. But I wanted to gauge from you if you've heard of different other types of strategies, and you're probably using them. And if you're in a healthcare setting, I think there are quite a few people here from Eastern Health where you're probably already always engaging in quality improvement activities. What types of implementation strategies have you used or have you heard of? So for this, you might want to use your chat box and just write down some examples. Is that right? Okay. Can I tell if people are writing things now? Here?
You can see it in the chat box.
Oh, no one's writing anything. Ah. Yes. I'm just going to make a few notes. Okay, so yes, another plea for people to share any examples if you have any, so that I'm not just talking all the time. Okay, well, we'll move on to the next slide. And we did have a response or two, and that was around using policy to restrict access to tests or treatments. So that is quite common, I think, and a good one to put in place, but it's then determining how we can put that policy into practice. So there might be different ways that you could do that. These are the usual suspects we hear about a lot. So reminders. Okay, I'm going to come back to a couple of comments that I've just seen pop up. Audit and feedback is one of their reminders. They could be point of care reminders. They could be reminders that come out in a monthly newsletter. There's different modes of actually implementing that particular strategy. Information on outcomes. So if the issue or the barrier is to using new guidelines that you don't think that works for your patients, which is very popular and a common one, I can definitely understand that, then you might need to use information on outcome and provide more evidence-based information on what why you should be using the new thing. So if you can't explain that to your audience in a way that's understandable, then that's a major problem for implementation. Lots of people use financial incentives. We do know that from the literature, the financial incentives tend to be decent for short-term change, but once the incentive is taken away, they probably don't support long-term change. However, if the financial incentive and the cost savings that you see outweigh each other, so you save more down the road if you do provide small financial incentives, it may be worthwhile. Credible source, benchmarking, opinion leaders, local champions, professional rewards. So if you're offering people education points, that type of thing, that's quite common. I do have one here. It says developing collaborative practice groups to make change. Yes, so that's another one I haven't put on here. It's called a few different things I've seen in the literature, where you are creating, I think some people call them circles as well. There's different terms for this particular strategy, but building collaborative groups to support change, and usually they will have sort of a local champion or an opinion leader with that group to help roll out and spread the word sort of as the practice change is happening. So those are some examples, and in a subsequent webinar it would be great to kind of go through these examples in more detail to look at what we know about their effectiveness in different contexts, because they do have different effects in different types of situations and scenarios. So I'm going to spend the last few minutes before questions looking at an example that we've done more recently when I was in the UK. So in the UK, about 4 to 5 years ago, they started a new initiative where they wanted to support collaboration between researchers and clinicians and, again, reduce this knowledge translation gap. So they created a fund called the CLARC, which is the collaboration between allied health professions and leaders. I can't remember what it stands for actually, but it's a fund of money that has been given to different groups in the UK to help support this collaborative effort between research and practice. So I was involved with one project underneath this initiative called the Backskills Training Program. So this particular program was developed by Professor Sally Lamb and her team in 2005, I believe, and it was shown in a very large randomized controlled trial to be a cost-effective and effective treatment for patients with back pain. And then that evidence kind of just got sat on the shelf. It didn't really do a lot. So underneath this new funding umbrella, they were able to consider how they can translate that information to get it into practice. So the first problem that they encountered was that the training that they offered in their randomized trials, so this would be one of those phase 3 trials I was talking about before at the beginning of this lecture. We do them really well, and then nothing happens afterwards. We just kind of hope that someone will take that information, put it into a policy document, and then hope that someone else will take it up and try to implement it. And I think that that's a bit sad, because we're really letting ourselves down as researchers by not ensuring that our information is at least making it to the right people. So through this, they identified what were they going to have to do with their training program to make it accessible. And it actually involved a face-to-face training program that they didn't think would be sustainable and didn't provide enough access to train clinicians in the program. So in order to scale it up and make it more accessible to people, well, at least in the UK and then internationally if there was a need, they decided to make the training into an online format. So from face-to-face to online, and then they looked at that as within a randomized controlled trial to see if they were similar, if they produced similar outcomes for knowledge, skills, and satisfaction among the clinicians. And so they do seem, it was a pilot randomized controlled trial, but in that small study, there seemed to be very little difference between the two training methods. So that was quite a good a good thing. However, it didn't matter which training method they used. No one implemented the training program after they received the training, which is a bit, actually it's not very surprising probably. Once you get some training, implementing it into practice is a much different kettle of fish. So when I was in Oxford, that was one of the roles that I was responsible for, was looking at how we can develop an implementation plan. So I worked with Dr. Helen Richmond, who developed the online training program as part of her PhD, and we developed a knowledge creation and translation plan. So this involved those two kind of approaches that we talked about before, include brokering, where we engage in deliberate dialogues with policy. So in the UK, those are clinical commissioning groups who are the ones who are responsible for determining which services will be provided in healthcare settings. We met with hospital managers, we met with the clinicians, and we met with patients. And at each of these particular dialogues, we looked at our problem of implementing this into practice and to see how do we do it? What do we need to do with this information to make it usable? So from that, we identified that we needed to engage in knowledge synthesis activities in a formal manner and an informal manner. So we updated the evidence on this type of treatment for patients with back pain in a large meta-analysis. But then we also provided a context-specific one that was really geared towards the clinicians and the context we're interested in. So we only included studies that were related specifically to that context. And that provided a really good basis for understanding if this information could be translated in this setting. We also answered clinician-driven questions that came up from the brokering process, which we would never have thought about before. So problems with implementing it were a difference in the patients that they were seeing, or that they thought there were differences there than the ones that should be receiving the treatment. So we did reanalysis of data sets and worked with them as part of the author group on the particular paper to gain understanding of how we could improve that information. And then we also used informal synthesis to create policy briefs for the clinical commissioning groups in policy who wanted business cases as well, and to show how we could, I guess, the cost savings that it could provide in different settings. And we used promotional videos and conference booths to get people engaged in talking about this particular program. We created a proposal for behavior change based on Helen's work in her PhD, which identified that physiotherapists was the target group that we were looking at. We wanted them to adopt the biopsychosocial approach instead of the biomedical approach. So a lot of surveys have been done and conducted in the UK to identify that a biopsychosocial approach was not being used to treat patients with back pain. It was largely biomedical, which is pretty normal because that is the training that most of the physiotherapists there would have received. And there's biopsychosocial approaches are, not that they're very new, but they're not, they're just been built into the curriculum more recently in the last 5 to 10 years. So a lot of people who are practicing may or may not have seen them or become familiar or comfortable with using those strategies. So this was a proposal for behavior change. Then what we did was we assessed the barriers and facilitators to making that change, and we did that through a thematic analysis of focus group and interviews with clinicians, and we coded it with a TDF. So we were just talking about that theoretical domains framework, and came up with this fancy diagram that I did not design. But it looked at, there was actually quite a lot of barriers, and they mapped to quite a lot of domains around knowledge, skills, beliefs about capabilities, and beliefs about consequences, and social influence was a big one. So having peer support and managerial support was a very large barrier. And we also engaged in discussions with the clinicians themselves to ensure that these barriers were the ones that were important to them. This is a description of how you might select strategies. It's not the best diagram, but ideally what we did was we took information from the behavior change technique taxonomy, so it would be the theory and the evidence that might help us understand the best ways that we could target things like social influence. but we mostly relied on information from the clinicians themselves. So getting an idea of what they wanted to be able to make this training usable for them, that they would feel comfortable using the program as part of their routine practice. So as an example, if we look at monitoring, no, that's probably not the best one. I think skills rehearsal is a good one. The problem with this particular training method is it's online. It's similar to what we're doing now. We don't have face-to-face training that would be sustainable. Therefore, we wanted to make sure that what we're providing could be rolled out long-term. So for skills rehearsal, rather than have a practice environment where they come in and do it in front of somebody, they had case vignettes. I wouldn't say it's the best strategy, but it's the one that was going to be sustainable within the mode of training we're providing. So that's just an example. We use a lot more promotional videos with people in their professional practice that promoted the training so they felt confident using it as part of their professional practice. And this is an example of some of the enhancements. So one of the biggest things that we wanted to do was to get it accredited with different societies. So it was accredited with the British Psychological Society, and it also earned CPD points with the Physiotherapy UK group. So that was to tackle the role of professional, or to tackle the barrier, of professional role and identity, where maybe using different strategies that promote self-management but also look at a bit more of a biopsychosocial approach, people didn't feel confident that it was within their scope of practice to be able to do that. So while I think that's a really big barrier and it's a really good one to address, because the different strategies involved in this particular training are not wouldn't be part of sort of a psychological treatment. They're just based on a psychological theory, so it's very different. So that was a presumption and a perception we needed to change. We also included here in the middle a lot more about the patient voice and the patient perspective of this training program. So there wasn't any information on what the patients thought of doing this program, so that none of that was published. So we looked at the documents from the patient perspective, and we summarized those in different videos, and we engaged with our patient representatives on our steering committee to get their opinions and feedback on those as well. The evaluation of this particular implementation strategy is underway, so I won't talk about that very much because it's still in its interim stage, but it's rolled out across in 20 different health trusts, I think, in England at the moment. And we have, I think, closer almost now to 40 sites participating in a service evaluation. And as far as I understand, and I don't know too much about the implementation at the minute, but in those 40 sites it is being implemented as part of routine practice. So that's really promising. This is a slide for further reading, just from the BMJ, if you want to know a bit more about implementation research in general. But before I go to questions, I just wanted to mention that in this particular piece of research, we used a patient and public involvement group. So every research project that is done under this particular funding umbrella in the UK is assigned a PPI group. So it's a support group for how you can engage public and patients, or how you can involve public and patients in your research. And largely that is having them on your steering committee, and as I was saying, through this process, reviewing your documents with them at each stage. But more recently, that group has now been renamed to PPIE, which is Patient and Public Involvement and Engagement. So clearly, they're trying to improve the process of getting patients and public more engaged in research along the way. And we could have done that as well, but we did not in this process. So they're only part of a steering committee. And there are multiple places throughout this process where you could engage with your public and your patients more regularly. And I think that you'll be learning about how to do patient engagement strategies as we move forward in our webinar series. So I think I can just open it for questions. So if you have any questions about what we've just discussed, please feel free to ask them in the chat box. We probably have time for one or two, and any others that come through we can answer and send out in an email. Is that right, Nina? Yeah. Well, if there are no questions right now and you think of any, you can definitely email with any questions that you'd like, or if you want more information around particular topics, I'm more than happy to provide that at any time. I know that Eva has some slides that she'd like to go through now before we end the webinar, so I'm going to pass it over to her. There are specific, okay, I have a question. Okay. Are there specific examples in Newfoundland? Yeah, so I definitely have some, I'm working a lot with, I guess, patient or physiotherapists here in Eastern Health, and we probably have some good examples there. They're not worked through like this particular one was, but we have engaged in quality improvement initiatives where we have identified, as an example, when we treat particular patient groups, we're not using those outcome measures that we should to really determine patient benefit. So we did a chart audit to identify how we were managing a particular patient group, and that was one of the key outcomes, was we're not really assessing outcomes that are the guidelines that we should be assessing. So we don't have a real good understanding about the benefit that we're providing to our patients in that group. So what we did was, well, at the moment, I think what we're doing is we put in place a bit of a checklist to make sure that the outcome measures are going to be used at discharge, and then we can monitor them later to determine if patient benefit is improving or if we need to modify the program. And I think what we could do to improve that is to engage with the patients more about their experience with the treatment, and not just from their satisfaction surveys, but a bit more of an in-depth understanding, and having patients guide the process of the research would be important as we move forward in those quality improvement projects. I think I'll hand it over to Eva now because we don't have much time left. But any other questions, just send them through. Okay. Thank you.
Just a few slides before we end this webinar. If you have any other questions, please add them to the chat box, and we will answer them either by email or later on. We will stay in this room for a little while, so please share all the questions and comments that you have. I would like to announce our next webinar session. Today we talked about change management, and next webinar will be about measuring value for money. So more about health economics. And this will be November the 10th, same time. And you have to enroll for this webinar as well on Eventbrite, so please register online. We have 2 webinars in November, so we have a next one, webinar 4, on November 24th. Which is about grant writing with a patient focus. So especially important for people who are interested in our grant to learn more about the requirements and to ensure that your grant writing is patient-oriented. So we have 2 webinars coming up, and we are looking forward to see you again online. And please share your comments and experiences. We have a SurveyMonkey tool, so please share your comments and experiences. We will share this link as well by email, because we're still learning, as you experienced today, how to deliver these webinar sessions and how to reach out to everybody and ensure that everybody can hear as well. So the webinar will become available on our website, as well as the PowerPoint presentation. And so you're able to review it, and if you have any other questions to Amanda or for me or about any other support topics, please let us know. I don't see any other questions for now, so I would like to thank Amanda for her presentation. I think we learned a lot about how to implement research finding into practice, and I'm looking forward to hear your comments and experiences. Thank you all for joining us today.